Yeah, Dr. Varma did a very good job, he almost convinced himself, I think, because it's a very interesting data that he showed. I'm lucky that I couldn't find my file so I can defend myself. Otherwise, I would be destroyed. So some disclosure. So I show the same slide about the freedom from progression. I'm going to show the standard of care in Hodgkin's lymphoma for stage 1 and 2 is ABVD 2 plus involved field radiation. Some people say that if you are early, based on a Canadian study, if you are in an early response, you do a couple more cycles and you are done, and radiation probably can be dismissed. This is not proven on a randomized trial, at least as of now. If you have a bulky disease or you have advanced stage, depending on your risk factors, you receive chemotherapy, 6 cycles, and there are debates about using BCOP, escalated BCOP, or ABVD at this point. Some people use a Stanford 5. Now you cannot get the muster of a Stanford 5, so I don't think you can do that anymore, at least in the US. So again, going to the same principle that Dr. Varma say, early relapses within 3 months, including all the refractory patients. They're not the same to say that somebody have a near complete remission and is refractory, or having a patient that have a progressive disease on chemotherapy, which is a very rare situation in Hodgkin's lymphoma, and usually prompt us to repeat another biopsy to be sure that there's no hiding a large cell lymphoma, or review the path to be sure this is not one of those gray zone lymphomas. Late relapses, more than 12, and of course the refractory in less than 3 months, and the very late ones after 60 months. You have residual masses, and PET positive after treatment is, you don't know quite sure if it's active disease. You can do a biopsy, it can be negative. So you end probably, if it's localized disease, consolidating with radiation and hope for the best. And that's what many people do, especially if the residual mass is quite small. See, this is a survival according to early relapses and refractory disease and late relapses. So you can see, the probability of outcomes after secondary treatment. So these are the options. There are 4 scenarios here. A 34-year-old patient with a stage 4B received ABVD times 6 cycles. He remained in CR. 2 months after this treatment is finished, he's had progressive disease. So in theory, it's called primary refractory. The patient is treated with something that they use in British Columbia, GDP, gemcitabine and cisplatin, achieving a PR. So the question is, what do you treat? You treat this patient with transplant. Second case, a patient received 34 years old, 4B, stage 4B, got ABVD, CR, 8 years later, progressive disease. Again, salvage chemo. What do? Transplant. I'm going to show you why I'm doing this. And then you go to another patient group, 34-year-old with advanced disease, Shiva CR, 2 months later, another progressive disease, and you're always going to do transplant no matter what, and I'm going to show you why. First, let's talk about salvage regimens. What the salvage regimen most commonly used in the U.S. is ICE. I think every patient should be put on a trial when possible. And the combination of trials like Dr. Risha, Dr. Varma using panovinostat with ICE are ongoing in the U.S. ESHAP, DHAP. I don't use Dexabeam. I don't know if any of you use Dexabeam. I don't use Dexabeam at all. GND is a very good regimen, and gemcitabine Doxil with about 70% outpatient treatment acceptable toxicity. IgEV, more toxic. The Italians claim to have almost an 85% response rate. Anyway, many different options for the patients. And this is the trial that Dr. Varma showed. He showed I have to say, Dr. Varma, were you in law school? I mean, he makes the points with something that is difficult to make the points. He makes the point that no different survival in different subgroups. But this study only have 120 patients. So you start to divide it in groups, you end with no patients in each group. So you cannot have a power to be able to say that this is good or not good enough. But in any case, what you see here and most of the patient progressive-free survival is going to be important in the long run in survival or quality of life. But in any case, this trial used Dexabeam, and then if you responded, you went for transplant or you went for more chemo. And this is the group. After randomization, the whole group, transplant did better from freedom from treatment failure. So simple. Patients have better progression-free survival, but no difference in survival. Dr. Varma is right. Early relapses. Patients who have early relapses receive transplant or chemo. Still 0.0075. And you can see the Kaplan-Meier curves. They show that the high-dose chemotherapy have better outcomes. If quality of life depends on not getting treatment every 6 months, it's important. Late relapses, more than 12 months. Same thing. You have more than 12 months, high-dose chemo benefit much better, even though chemo have more activity. Now you can make a point that say you can use panovinostat. I don't know if any of you has been treated a patient with panovinostat. They get nausea. It's good for losing weight because you don't eat too much, and your platelets rock bottom down. It's not something that you want to take if you want to have a good quality of life. Interesting drug. SGN35 or brentuximab, I don't know how much cost in Australia, but it costs probably about $30,000 a pop every month of treatment. If the patient responds for 6 months, you're ending with $180,000 of treatment, and you're going to relapse at 6 months probably, or 9 months. I mean, you have a median duration of response of about 6 months. Revlimid, I think Revlimid is a little less than 30% responses. In some publications, I'm seeing $7,000 a month for treatment. So you end having about $42,000 in 6 months if you happen to respond. So financially, it's a burden, and the activity is limited. So I think, it's simple to say that probably what we need to improve instead for today is our options of treatments, how to recognize who is going to fail. So I think Dr. Varma did an outstanding point defending something that is difficult to defend. More relapse. If you relapse on the first time, you do better. But Dr. Varma say it's true. After second or third relapse, the role of transplant starts to get worse. So probably we need to transplant the patient on the first time he failed, not going for the second or the third, because their chances of collecting stem cells or helping the patient goes down. Refractory patients, they don't do well, but they don't do as horrible. I mean, this is survival. This is not progression-free survival. But you can see that after 20 years, probably near half of the patients still alive, but you had to do transplant. If you remember, only 30% of the patients will respond to SGN35 when they were not candidate to transplant. This data was pulled by 2 different trials, and the 2 trials that were presented or discussed, most of the patients were because they were not responding. But there were some patients who were refusing, and they were old patients too, who did not qualify for transplant due to age. But in general, Dr. Varma is right. But 30% responses, $40,000 a month, I think I'd rather do G&D. It's much cheaper than doing a treatment with SGN35 and have a 70% response rate in most of the publications. So relapse on refractory do worse, but transplant can help some refractory patients. Now, before I don't have this slide, but if you see different publications about the use of allogeneic transplantation in patients who fail an auto transplant, is very controversial. And why is controversial? Because depending on what place you treat and transplant patients. But at MD Anderson, Dr. Andolini reported our data in where patients who fail an auto transplant, of course, Andolini takes his time to do the transplant, so you have to be alive to make it to the second transplant. But if you have achieved a complete remission, your chances to be alive after a second transplant were about 50% and in remission. On the other hand, if you have anything less than a complete remission, your chances of being alive in remission will be, I think, 12%. So if you have a patient who is probably having a long time of remission with the first auto transplant, and you can put him in a decent response, after a third line of treatment in this case, probably you can consider doing an allo if he's in CR, because they might benefit with an allogeneic transplantation. And this is something that we did at MD Anderson. You know, we use PET and gallium. We didn't have that many gallium PET patients, so we had to use both combined. And Dr. Moskowitz in Memorial did the same publication. We got it in cancer, he got it in blood, even though it was 2 years later. But in any case, this is what we show. We show that patients who have PET scan positivity before going for the transplant, they only have a 2-year disease-free survival of 30%. This doesn't tell you that you don't have to do transplant. This just tells you may want to put patients on investigational trials. You know, for instance, at this point, there's a trial ongoing in the country, the US, and I don't know, I think they involve Europe too. I don't know if Australia is involved, where patients are transplanted and they are randomized to a maintenance trial where the patients receive either SGN35 or brentuximab or versus placebo. I think that's an interesting trial for this group of patients. You know, if the PET scan is positive after salvage chemo, the likelihood of long-term remission is low. On the other hand, if the PET scan is negative, the 2-year disease-free survival is 65%. So that identifies patients who have worse prognosis or better prognosis. It doesn't mean transplant won't benefit them, but you can use something investigational, double transplants, maintenance brentuximab versus placebo, or investigational trials, like we have a high-dose GEMSAR trial. We have interesting results with these patients. In summary, you know, this is what happened to the patient who relapsed after auto transplant. This is by Dr. Horning. And what you can see, the patients have a relapse after transplant within 12 months. The patients have a short-term survival. If they have more than 12 months, they do better. So it's important that those patients are actually, I follow the Dr. Varma and Dr. Ritchie, those patients should be put in trials, especially the group of less than 12 months. In conclusions, if the patient is fit, have a recurrent disease, regardless of the timing of the relapse, salvage chemotherapy followed by standard of care stem cell transplant is the appropriate treatment. Now you can use different investigational transplant approach. The first thing that probably we want to be sure is that relapsing. You know, we have some cases of sarcoidosis, of relapses of sarcoidosis instead of being Hodgkin's. We have histoplasmosis. We have a bunch of OCs, you know, including second cancers that were not relapsing. And sometimes we have large B-cell lymphomas relapsing after a Hodgkin's. We try to do investigational trials in most of the patients when we can. And if you fail after an auto transplant, I think brentuximab is an excellent choice, but also consideration for other drugs should be done and participation in trials. An allogeneic transplantation may have a rule in, I don't know what Dr. Ritchie, who is a transplanter, opinion is, but in patients who are late relapses or, you know, they're recovering from the toxicity from the first one, have a good donor and an excellent complete response, you know, a complete response, probably they are good candidates for a second transplant in this setting. Thank you.
Excellent. We have some time for questions. I'm back transplanting again now. Brentuximab is a useful drug. Of course, none of those things may be mutually exclusive. You might do more than one of those things in combination. All right. So, questions. Who has some questions? I'll get the ball rolling. So, Dr. Fayad, second autologous stem cell transplants. What do you reckon?
I think there were some people from New York who used to do, we did, when I was a fellow, we did 9, and the second transplant was with thiotepa, so the patients lost all their mouth, you know. So it was very toxic, but I know there's a Dr. Mahmoud, I think, or something in New York used to do those. I think that in Europe they're doing some tandem transplant for Hodgkin's. I think might have some value in some patients, but it's something on the research. I think the toxicity is an important issue. I think probably patients who have a poor prognosis like persistent or PET scan before the transplant, they can be considered for that new strategy, not just to the standard stem cell.
I meant a second transplant as opposed to a tandem transplant. So a second transplant after relapse from a initial autograft.
Well, I remember the European bone marrow transplantation registry published their data many years ago, and they only have 12 patients. And I think 40% of those did a good, but they were selective, like they were like more than a year, and they were able to collect the second time. So they were only like 12 patients, if I remember, because I researched that many years ago. I don't know if there's new data on that.
There's been some recently published data to suggest that with late relapses, with chemosensitivity, all those things, good performance status, that there may be a salvageable portion, 30 to 40%. A question?
Yeah, I just want to make a comment. Professor Verma made a point very clearly against the transplant. But another argument which he could probably have highlighted, the long-term side effects of transplant, especially the second malignancies and others, which could be that not to really do the transplant. I think Dr. Verma probably didn't include that. Fine.
You may need to borrow.
Okay.
There we go.
I think there is not enough data really to say that how much is the difference in second malignancies. I could get only one report where they said that in one group there were 3 patients with acute myeloid leukemia, in another one there was 1 patient. So even though there is a kind of feeling that with a very long survival in patients with Hodgkin's disease, you would like to reduce the long-term toxicities, and that's why people have actually done away with the radiation treatment in the first line for many of these individuals. In the salvage, actually, you use chemotherapy and you also use local radiation. So it's quite likely that if you have these patients followed up for a longer period of time, you might have higher rates of malignancy. But for a debate, you actually required a clear data to show one way or the other, and I did not have that. And in fact, I think it was a clear case of mismatch, predominantly in a situation where something is accepted, and there is nothing which is actually accepted on the alternate side. But to my mind, maybe 4 years later, when you have a debate, then you will have slightly different perspective. Because the cost issues, the long-term complication issues, and so on are issues which we are debating on today's prices. But once drugs are being used and you have a market for drugs, sometimes the prices actually come down, and then you can see what is the cost of these over a period of time.
No, actually, I was trying to be in your favor.
Yeah, I understand that, but then I'm actually, as I said, I'm devil's advocate, so I was now going against that.
We wrote a commentary in Lancet in 1995, and that time when we reviewed the earlier data of transplant between 1990 to 2000 or so, the second malignancy rate used myelodysplasia and second malignancy used to be between 5 to 8%. But now clearly after the gaining more experience, this has come down to between 1 to 3.5%. So this is much lower because we are doing more elective transplant, but it's still there. It's not, it's gone totally.
But going to the other side, you also have leukemia when you have more treatments. And in the old times, they used to have more mustard. People don't use mustard anymore, unless you try to use high-dose pickup, something you have more toxicity too with the toposide. But I think still today, transplant is more, if you have longer responses, you have better quality of life in general.
I think the other part which has not been discussed is the nodal lymphocyte predominant Hodgkin's lymphoma. That is one situation where you would not like to transplant. So maybe you can comment on that. What we have discussed is possibly the classical Hodgkin's lymphoma, not the nodal lymphocyte predominant.
Lymphocyte predominant, gentlemen?
Yeah,
approach?
One that it's a relatively uncommon disease, and the long-term results are so good in nodular lymphocyte predominant Hodgkin's that even if it relapses, you could use chemotherapy. And there is a role of rituximab now in treatment of this subset of patients. So I think the treatment paradigm for this is entirely different. And since I thought that the number of patients who would be going in for transplant would be so low that it was not really worth mentioning in the debate. But because the data basically says that nodular lymphocyte predominant Hodgkin's disease would do better than the classic Hodgkin's over a period of time. They respond better to treatment. And even at relapses, they actually respond better to treatment. And with the addition of rituximab, most likely you would have very little need for doing something different in them.
Well, nodular lymphocyte predominant Hodgkin's disease is a misnomer. They shouldn't be called Hodgkin's disease. It's a different disease. You know, it's a non-Hodgkin lymphoma with an old name. You know, and I think in localized disease, especially very localized disease, patients should be treated. Radiation is a good option. You know, I think rituximab is a palliative option in some patients. You know, the responses were very high with single-agent rituximab, but they didn't last. The median duration of responses by the Stanford group, I think, was 12 months. So it's very limited, you know. I think most of the people with advanced disease, you know, with lymphocyte predominance, first I want to be sure that this is not a T-cell rich large B-cell lymphoma, which sometimes can transform or can evolve from the lymphocyte predominance or being a mistake by the pathologist. And I think many people, at least in our institution with advanced disease, when they need treatment, we probably will treat them as a large B-cell lymphoma with alkylating agents. And I think many people train to do that. ABVD is for Hodgkin's, not for lymphocyte predominance, because in my opinion, lymphocyte predominance is not Hodgkin's, you know. And I don't know if everybody agree with that, but that's what we think. I don't know if you feel the same way. Excuse me? Something that you cannot treat with radiation, you know. If you cannot use radiation, it's advanced.
So do you use RABVD or R-CHOP therapy for the?
Probably I will use R-CHOP, you know, but I'm sure there's some data. There will be some other situations. Recently, I saw a very small publication using R-CHOP and radiation to the involved field for localized disease in multiple sites. But I think if you are outreach of a radiation therapy, I think R-CHOP probably is a good choice. SWOG is doing a trial. We collect our data with R-CHOP, and we had long-term, Dr. Fayad published that, and we have very interesting results long-term with R-CHOP, you know, and I think SWOG is opening a trial now using R-CHOP for advanced lymphocyte predominant Hodgkin's.
Is it true that MD Anderson was also doing RABVD in nodular lymphocyte predominant thing?
No. Actually, UNIS will not include those patients on the trial because they were considered other diseases.
Last question, please.
Just two comments. You have shown one of the data that RABVD works even in patients who are not CD20 positive. Any possible mechanism you like to make any comment on that? And secondly, since we did not cover allogenic transplant, would you like to make any comments on allogenic transplant? Maybe David want to say something on that aspect in Hodgkin's disease.
I mean, I found the presentation or of the data that CD20 expression on the Reed-Sternberg cells was not mandatory for the efficacy or the apparent efficacy. Remember, this is a single arm analysis, and the randomized study still has to come out. I can do lots of hand waving, I suppose, about the microenvironment of Hodgkin lymphoma, and that's probably what's going on there, but I wouldn't want to speculate too much. There is good data to suggest that certain subgroups of B cells have a regulatory effect and may suppress anti-tumour T cell responses. So that would be my theory on that. Allogeneic transplantation, I do allogeneic transplants on Hodgkin's lymphoma. We do increasingly number of cord transplants in Hodgkin lymphoma. I'm sure there is a graft versus Hodgkin lymphoma effect. I don't know why we see it in some patients, why we don't in others. It's worthwhile doing in patients who have got porous disease and have relapsed post-transplant. I think the timing of allogeneic transplant and brentuximab is still being worked out. Relapsed Hodgkin lymphoma is a mystery disease. Some patients do marvellously well and some do marvellously terribly. And it's very hard to figure out who's going to do what. Any last comments? gentlemen. I think we've used our hour and a bit very effectively. I think I'm going to hand over the chairmanship to Dr. Wanachi Wanawin for the next session. Thank you very much.